Hi, Dr. Scott Nelson here. Today we're going to talk about trauma and anxiety, neurobiology, and best practices. So basically, the discussion today is about how trauma, post traumatic stress disorder, for example, and anxiety work in the brain and what we do about it. My name's Scott Nelson. I am a clinical mental health counselor with a private practice in Rockford, Illinois, and Crystal Lake, Illinois, and I'm also an associate professor at Judson University, where I teach graduate counseling students. You can also check us out at www.counselingtransforms.com if you want to know more about me. All right, so let's get started. Trauma. Trauma tears up an individual's psychological anchors, which are fixed in a secure sense of what has been in the past and what should be in the present. The event propels the individual into a traumatic state that lasts as long as the mind needs to reorganize, classify, and make sense of the traumatic event. Then and only then does the psychic equilibrium return. What this means is that when our brain experiences trauma, then it disrupts our sense of what is, in essence, our worldview. And so healing from trauma is about making a new sense about our world and us and whatever else was affected by the trauma. But peritraumatic, which means around or like the trauma, is about immediate, vivid re experiencing of the traumatic event. And this can be very disconcerting for clients. And so it's an intrusive kind of a thing where we might have flashbacks, and it's not something that we want, but we experience it anyway. Hyperarousal is another one of the responses, and that basically means that someone is super alert, super aware, always on edge, always looking for a threat, and trying, in essence, to protect ourselves. The other one, and this plays out in diagnosing and treating, is avoidance reactions, and that would be avoiding anything that reminds us of the traumatic event. And it doesn't have to be a direct reminder, it can be almost an association kind of thing. Acute stress disorder in the DSM 5 lasts 2 to 4 weeks. The dissociative symptoms present are memory loss, detachment, belief that things or people are unreal, a blurred sense of identity, and a general disconnect from reality. Interestingly enough, the more dissociative symptoms that surround the traumatic event, the more likely someone is going to develop post traumatic stress disorder. The difference between acute stress disorder and post traumatic stress disorder is really the longevity of the symptoms. So, if something lasts more than 4 weeks, then it would turn into post traumatic stress disorder. So, what we need to do when someone is traumatized is tackle the acute stress disorder symptoms and get treatment immediately. The quicker the treatment, usually the better the outcome. And unfortunately, acute stress disorder symptoms are predictors of post traumatic stress disorder, which, as I mentioned earlier, lasts longer. So, if the event is not effectively integrated and is submerged from the conscious awareness, then the probability is high that the initiating stressor will continue to assail the person and become chronic post traumatic stress disorder. So, one of the things to remember is that if someone has symptoms of acute stress disorder, if they don't deal with it, it's very likely that it's going to become post traumatic stress. So, we don't want to avoid symptoms, and we don't also want to avoid treatment. So, the sooner somebody gets help, the better. Interestingly enough, kind of how the brain processes things is think of your brain as an anticipation machine. So the brain acts like an anticipation machine that continually prepares itself for the future based on what has happened in the past. Now, memories shape our current perceptions by creating a kind of filter through which we automatically anticipate what will happen next. In this way, the patterns that we encode in memory actually bias our ongoing perceptions and can change the way that we interact with the world. So, our brain is constantly taking in new information, trying to make sense of it, integrating that, and making sense of what's going on with us, with the world around us, and circumstances. And so, then what it does is it kind of projects into the future to try to identify what's going to happen in order to prepare for that. And trauma can really kind of interfere with that whole thing. Memory plays a big role in post-traumatic stress as well, and this is kind of interesting. There's two major kinds of memories. Implicit only memory, That's the one that really can be involved in post-traumatic stress. And then explicit memory is another thing that can be kind of confusing when the symptoms occur to someone that has experienced trauma. So think about implicit memory. Someone riding a bike, there's that saying that once you learn, you never forget. And so if I know how to ride a bike, I can get on it and just take off riding. What's interesting about how the brain works is that even though it seems like it's automatic, I just know how to do it, and it doesn't really take any conscious thought, my brain is actually pulling from memory files in order to accomplish this task. It's just something that has been programmed in there, but I'm not consciously aware that my brain is doing this. Explicit memory is think back to maybe I'm guessing that you learned how to ride a bike. If so, then think back to the day that you learned how to ride a bike. Now notice the difference. When you think back, you're aware that you're pulling from a memory file. Interestingly enough, again, with the other kind of memory, we are still pulling from a memory file, but there's no conscious awareness that we're doing so. So implicit memory generalizes from our experience, and usually there's about 6 domains of implicit memory depending upon what research we look at: perception, emotion, bodily sensations, behaviors, mental models like making sense of things, and what's called priming. Implicit memory and priming. Priming is where the brain readies itself to respond in a certain way to a certain stimuli, drawing on things from the past like perceptions, emotions, bodily sensations, behaviors, and mental models. The brain becomes that anticipation machine, always preparing us for the future by generalizing from the past. In implicit memory, there are 3 unique factors. Number 1, it doesn't need conscious attention to form. So that's going to become important in a couple of minutes when we get into how that plays out in post-traumatic stress. When implicit memory is active, there is no sense of recall. In other words, we are pulling from memory files, but we are not consciously aware that we are. And it doesn't need the hippocampus to do this. So the hippocampus is another big player. Implicit only memory is experienced in consciousness, but it is not tagged or felt as something emerging from the past. Implicit memory, so when we are having for example, those intrusive thoughts of a traumatic event when it's kind of replaying in our mind, there is no conscious link to the past. So what we might have is feelings in the body, emotional reactions, perceptual biases, and behavioral responses to a pattern. And what's interesting too about this is when someone has these kind of emotions and feelings and reactions and perceptions come out of, quote, nowhere, unquote. And we assume that our judgment is good in the present, but we're actually pulling memory experiences, feelings, biases, and response patterns from the past. Explicit only memory is observable by the age of 2. It requires attention and integration, creates a scaffold of knowledge, again, to kind of make sense of things and for us to put things into a perspective that makes sense so that we can relax and go about our lives. We are aware when we're retrieving it, and there's 2 forms, factual and episodic. Factual, think of that as small bits of data, and episodic is like an episode, like a TV series has episodes that are made up of like small acts in that TV show. The interesting thing too is that explicit memory requires hippocampus. So hippocampus is what kind of categorizes and puts things in order that makes sense to us. When you look at your brain, the hippocampus is kind of in the middle, note the arrow there, and is a part of the limbic system. It's a big player when it comes to making sense of things. So that's actually what it looks like. It's kind of seahorse shaped. And think of the hippocampus as the Google search engine of your brain. It searches for things, it places things, it pulls things, and it gives context. It's kind of like a master puzzle assembler. So it draws together the separate pieces of images and sensations of implicit memory into the assembles a picture or a factual and autobiographical memory. So it puts pieces in place so that we can make sense of it. Now, the thing is, the hippocampus can go offline. If you've ever heard of someone that has an alcohol blackout, for example, basically what happened is they consumed too much alcohol, and the alcohol in their system knocked the hippocampus offline. So, someone that has a blackout, they can be walking, talking, and those kinds of things, but later on they have no recollection because the hippocampus was not filing and putting the memories in some kind of context where it could retrieve it. And so that information is lost. Another way that the hippocampus can go offline is when someone is extremely angry, like rage, or cortisol, which is a stress hormone, and happens when there are intolerably high emotions or stress. For example, like a terrorist attack can cause super high levels of cortisol, that stress hormone in the system, and that can knock the hippocampus offline. If the hippocampus goes offline, that can lead to dissociation. And dissociation at the moment of trauma is perhaps the most important long term predictive variable for post traumatic stress and is invariably connected to complex PTSD. So, dissociation is when we go someplace else, we check out, we're not present any longer. And that can be for a short period of time or a long period of time, depending upon what's going on in our brains. But that dissociation at the moment of trauma predicts post traumatic stress disorder. Now, how this kind of works is extreme stress or trauma causes our system to be flushed with cortisol. Cortisol and the trauma reaction causes fight, flight, freeze, or we might add faint responses. The hippocampus gets knocked offline, and then dissociation happens, which is really a chemically induced blackout, not unlike an alcohol blackout. The hippocampus forms those episodic memories like TV show episodes, and the higher the hippocampus level of functioning, the higher our recollection. And the amygdala is a big player when it comes to post-traumatic stress. So the higher the amygdala is functioning, that causes hyperarousal, which weakens the hippocampus ability to function. And the amygdala has a competitive interaction with the hippocampus. Problem is, the amygdala is designed by nature to supersede the hippocampus when it comes to protecting us from a dangerous situation. Hippocampal activity is reduced when participants suppress retrieval compared to when they retrieve a memory, suggesting that people can intentionally regulate hippocampal activation to disengage recollection. What this means is that some research seems to indicate that there is a degree of willful forgetfulness when it comes to the hippocampus dissociating. So, to some degree, we can will it to happen and will to forget. Now, the amygdala is the big player. So, the amygdala are almond-shaped glands on either side of our brain, kind of where if you took a laser beam and put it through your eye and your ear where they cross-sect, that's kind of where those glands are. What the amygdala does is it initiates physical sensations of anxiety and fear, forms and recalls emotional memories. So this is not logical. It's an emotional memory or experience, and the amygdala scans experiences to protect us, and it responds to any sign of danger. And then what it does is it receives the information before our prefrontal cortex. That's the front part of our mind where we can make order of things and be logical. It reacts before our prefrontal cortex is even aware of what's going on. And the amygdala regulates fear and trauma memory. And it causes fear conditioning and fear generalization. Now, why this is important is think about if we're out in the woods and let's say we're hunting and there's a movement in the bushes or something, and suddenly I find myself running before I even recognize consciously that there's a bear there. So that's amygdala. Amygdala scans for threats and reacts quickly with fight, flight, freeze, or faint. The problem is now when there is a threat like that and my amygdala fires and it saves me, my brain locks that in and my amygdala goes, okay, bush rustling, danger, run. The problem with that is next time I'm walking somewhere in the bush rustles, I have the amygdala reacts to the associated threat, the bush rustling again, and pulls those old feelings and reactions and things into the present. So now a bush rustles and I find myself running even though I don't want to. That's the amygdala. It's trying to protect me, but sometimes it doesn't function very effectively in that regard. In other words, it overprotects me. Amygdala reactivity, heightened amygdala reactivity to negative emotional information is associated with future onset of post-traumatic symptoms following, for example, a terrorist attack. So the more heightened my amygdala is in terms of its reaction, and that the negative information that goes along with that, it programs my amygdala to scan for anything that reminds it of that threat, and this can cause post-traumatic stress. Also, elevated amygdala reactivity to negative emotional information could represent a neurobiological marker of vulnerability to traumatic stress and potentially a risk factor for post-traumatic stress. The amygdala and cortex worry. So these are two different anxiety highways in the brain. Amygdala causes fight, flight, freeze, or faint response, and the prefrontal cortex, where we make sense of things and are rational, that's where worry works. So those are two different ways that anxiety and fear work in the brain. So there's the amygdala, that's the one way. And here's kind of the amygdala highway of a threat response. I call it an amygdala-based fear response. So we have some kind of sensory information that hits us. It goes through the thalamus, and then it can go to the prefrontal cortex, to the amygdala, and that can cause anxiety and fear. There's another way, and that's where the sensory information goes to the thalamus straight through to the amygdala, bypassing the prefrontal cortex, causing anxiety and fear. That's when people say the fear, the feeling, the dread, the memory, or whatever comes out of quote unquote nowhere. It's when the amygdala is going off. It doesn't have anything to do with the prefrontal cortex. It's not logical, it's not orderly, and it bypasses that. And this can cause people distress because it can make them feel like they're crazy because it doesn't make sense. Well, the reason it doesn't make sense is because it bypasses the prefrontal cortex. So whether the amygdala is solely overreacting, leading to relatively decreased frontal activity, that's where we make sense of things and are logical, or underreactive frontal regions fail to suppress amygdala responses, or a combination of the two, this interplay between the regions likely leads to the problem seen with heightened responsivity to threat and altered emotional control, hence post-traumatic stress disorder. The fact that we have little control over the amygdala's rapid responses mean that we experience our fear and anxiety responses rather than consciously controlling them. Again, this is when the feelings, the sensations, the dread, whatever it is, come out of nowhere, has nothing to do with my ability to be rational or cognitive. Sometimes we refer to that as the amygdala hijack. The amygdala basically takes over the prefrontal cortex and neutralizes it. Now, amygdala has its own kind of memory, and what it does is it associates things. So, for example, I had a client that was almost killed in an accident with her car and a truck. And so it took a long time to get her back on the road. And even today, when a truck comes by, her amygdala reacts and she gets basically an adrenaline rush because the amygdala associates the truck, the sound of the truck proximity with her near-death experience. And so that's what the amygdala does. It's scanning for threats to protect us, but when it's misguided or misfiring, it causes symptoms of post-traumatic stress. This creates emotional memories. That's why these memories come out of quote-unquote nowhere, and they can be really intense, and they feel real. It feels like what's going on is now. I'm in danger today, right at the second, when in reality the threat is a memory. It's pulling from those files into the present, but I'm not aware of it. Amygdala memory lasts longer, and there's a challenge in overcoming the amygdala-based fear response and symptoms of post-traumatic stress. We have to basically reprogram our amygdala to do that. And the amygdala memories are kind of stubborn because they're designed to protect us. It doesn't need the cortex memories to react. Think of your amygdala as your protector. It's trying to protect you at all times. It's constantly learning. Unfortunately, we experience the amygdala going off directly as an emotional state that feels like it's now when it really is a memory feeling getting pulled into the present. It has nothing to do with being rational. There's something else called amygdala searing, and that's involving the amygdala and adrenaline. And basically, the memory traces are seared into that implicit memory. Remember, that's the memory that we are not consciously aware that we're pulling it into the present. This causes things like terror, perceptual details can come into the present, behavioral reactions, fight, flight, freeze, or faint, and bodily sensations, usually unpleasant ones. Fear is designed to get us to get away from something that is dangerous or fight it. And when the amygdala fires like that, the adrenaline rush that goes along with it can be quite intense, and it also causes things like panic attacks. And basically, a panic attack is an amygdala based fear response. Flashbacks are another issue. That's implicit only memory. It involves emotions, bodily sensations, and also behaviors. Remember, because at the moment that the trauma happened, the hippocampus went offline. It's not connected to a context from the past, and so these are kind of like emotional memories that are moving around inside of our brain and have no context. And the amygdala will pull them into the present to try to protect us, but rather it causes symptoms that are very unpleasant. And it seems like these experiences are now when they're actually a memory from the past. Because the hippocampus had been blocked, the raw moment to moment fragments of the experience remained as free floating implicit puzzle pieces in disarray. So, part of recovery from post traumatic stress is making sense of things and dealing with the unpleasant feelings that haven't been connected or put together or made sense of. And the other issue in dealing with trauma and these kind of free floating terror or fear reactions is they're very unpleasant. So, tendency is to avoid them rather than hold on to them and then deal with those emotional reactions and make sense of them. Post-traumatic stress is cross-cultural and is common to all people, so it affects basically all humans wherever we live. No matter how normal or stable a person might be, if the stress were sufficient to cross that particular individual's threshold, a war neurosis, quote unquote, would develop. And so, in essence, war neurosis is kind of a Freudian term for post-traumatic stress, and anyone basically is susceptible to post-traumatic stress given the right circumstances. Here's kind of how post-traumatic stress works. Okay, you've got kind of an equilibrium in our worldview and our ability to function, that we made sense of things and we're okay. And then a trauma happens. Well, sometimes when trauma occurs, we have sufficient coping skills and resources like social support, and so we can handle it. However, when too much trauma hits and it supersedes my ability to cope, that's when we develop symptoms of post-traumatic stress. Given the right trauma or a series of traumas, and that supersedes my coping strategies and skills, then post-traumatic stress is going to develop. So it can affect anyone given the right circumstances. Risk factors. There is evidence of a genetic predisposition to post-traumatic stress, anxiety, panic disorder, those kinds of things. However, given the right conditions, it appears anyone can be a candidate. So, but given the right circumstances, anyone can be a candidate for post-traumatic stress. So the idea here is that then there doesn't have to be a stigma that goes along with post-traumatic stress. The quicker someone gets help, the more likely they are to have fewer symptoms and get better quicker. And that part of that too is also about a willingness to deal with those emotions that are kind of floating around without a context. So in terms of the prevalence of post-traumatic stress in the general population, depending upon what research we look at, about 1 to 8% of individuals are likely to have post-traumatic stress. However, when you look at specific populations, military, law enforcement, firefighters, EMS, basically vocations that expose one to more and more trauma, it jumps up to 17 to 22%. And fortunately, law enforcement, military, firefighters, EMS, those cultures are starting to become more educated about post-traumatic stress so that members can get help and get better quicker. Now, for full-time firefighters, for example, that jumps up to about 37%. there is some evidence that post-traumatic stress is cumulative. In other words, the more trauma one experiences, the more likely they are to develop symptoms, especially if they're not dealing with the emotional implications of what they experienced. Treatment, let's talk a little bit about that. So, first part of treatment is processing and coming to terms with what happened. Then we need to master the physiological and biological reactions and reestablishing a secure social connection or connections. So, in essence, someone has to talk about the issue, deal with the emotions and things, make sense of them, and in order to do that, they have to have skills. So, they need to know how to like self-soothe with deep breathing or counting or grounding techniques, self-talk, those kinds of things. So when they have one of those amygdala-based fear responses, an adrenaline rush, they can work themselves through it. Usually one of the best things to do is deep breathing, deep diaphragmic breathing, and then there's also different ways of thought stopping if there's intrusive thoughts. More about that later. But the idea is manage the physical symptoms so someone can deal with the emotions that are associated with the event and then work through it, at least with friends, family, peers, but hopefully with professionals like me that are skilled in helping somebody to get better quicker. Best practices for treating trauma. Here's a list. The trauma-focused CBT. CBT is cognitive behavioral therapy. That's been shown in the research along with these other things to be effective. Medication when someone has post-traumatic stress symptoms. Prolonged exposure therapy. That is probably one of the most efficacious treatments, but it's also unpleasant. So, in essence, you have to kind of sit in the unpleasant feeling until the emotions that go along with it reduce by about half. Stress inoculation, which is similar. Cognitive processing therapy, CPT. Alternatives, one is EMDR or eye movement desensitization. That's becoming more and more popular, and also acceptance and commitment therapy, also known as ACT. These are all best practices for treating trauma-based symptoms, or basically the amygdala-based fear responses. Good news is it's very treatable. So approximately 40 to 80% of clients who have post-traumatic stress disorder get better with treatment. And medication is usually also important to manage some of the symptoms. There is no standard fixed pharmaceutical or pharmacological regimen for treating post-traumatic stress. SSRIs are the serotonin-based medications. SNRIs, the serotonin norepinephrine-based medications. And medication combined with counseling is usually the most effective. However, benzodiazepines, which are like a Xanax class of medication, are not recommended because what happens is the benzo class of meds do reduce symptoms of like the fear, the anxiety. However, they numb out the amygdala. So do you remember going back to the alcohol blackout? There's something similar with the benzos. It kind of knocks the hippocampus offline, so then it numbs out the amygdala and it interferes with the making sense and integrating the experience back into a cohesive kind of worldview thing. So benzos tend to interfere with the counseling aspect, whereas the selective serotonin reuptake inhibitors and the SNRIs do not interfere with the counseling therapy that goes along with the meds. These techniques directly target what individuals spend a great deal of psychic energy trying to cover up and submerge from reality. In doing so, they are exposing core beliefs and emotions that are likely to be terrifying. So the hard part of recovery from trauma and the amygdala-based fear response is that we have to face the things that we instinctively resist and push away. Things like vulnerability, fear, and all those symptoms that we have to go through to get better. So in essence, the only way to heal is to feel. And the point of the denial and things is because we don't like those feelings. So we have to go through that in order to recover and reintegrate and make sense of what happened into a new cohesive worldview. Some hints for exposure: don't push too hard too fast. So when I'm working with clients that are using exposures, I need to make sure that they have the skills to manage, I call it the feeling storms that happen when they sit in those feelings instead of running away or avoiding or self-medicating the emotions. So we need to make sure the skills are there and not push too hard too fast. We need to provide in-depth psychoeducation, which is one of the reasons for this video, because when people understand that their symptoms make sense in context, in essence, my panic and the sensations that I experience are my amygdala trying to protect me, it now makes sense to me. And so when it happens, it doesn't freak me out as much, because a lot of people who don't understand what our brain is trying to do and how it works can actually think that, like, I'm crazy, there's something wrong with me. That'll cause more adrenaline and greater symptoms. And so psychoeducation can help really take the edge off and move people along in treatment. The practicing grounding techniques and self-soothing, I find generally that when clients have the skills, like it's like their brain figures out, okay, I think we can deal with this now. And then those emotions start to pop up, and the clients are able to handle them. We also, as clinicians, want to make sure that the clients understand. So, like if you're a consumer, if you're seeking therapy for anxiety or panic or post-traumatic stress, make sure that your clinician is telling you about the process and how it works so that you're prepared. And as clinicians, we need to make sure that you, the client, understand what's going on and how we're going to proceed. And it's a good idea to have after-session debriefings, especially when someone is stirred up, because that's part of it. That emotional arousal has to be triggered and going on. The adrenaline rush has to be going on to reprogram the amygdala. So we want to make sure our clients are okay after the session. Traumatic stress. This is NetSmart, or My Learning Point. This basic training is available if you are a professional medical or mental health professional, or someone that would want continuing education credit for this training. You can go through this training at NetSmart or My Learning Point. That's www.mylearningpoint.com, and get CEUs. And thanks for joining me today for this talk about trauma and panic and post-traumatic stress and what to do about it.